All right, everybody. Thanks for joining. It's 2:01 in Eastern Standard Time, so we're going to go ahead and get started. We see a great majority of people. This is being recorded for everybody that misses part of it. We'll send the recording afterwards. This is our pleasure. JK and I are thrilled to invite you all and welcome you all to opioid settlement funding, an overview, an intro, and a way to leverage innovation inside of these settlement funds. We'll start with introductions and then we'll move right into the presentation. Feel free to use chat to introduce any questions you may have along the way. We can answer questions throughout, and then we have time at the end for a quick poll and some additional questions at the end. So without further ado, we'll get started. We'll start with introductions, everybody. I'm Phil Beck. I lead growth at Sonara Health. We are a technology company that partners with opioid treatment programs around the country to support them with innovating their treatment programs to allow increased access to take-home medication, done so safely through asynchronous observation of the at-home medication. And I'll turn it over to JK for his introduction, and we'll get started.
All right, thanks, Phil. Hey, everybody. I'm JK, and I'm a physician consultant. I work with the Steadman group here in Colorado, and I see a few, I think I saw about 5 Coloradans here, Jess, Risa, a couple others. So thanks for being here. And the Steadman group helps with population behavioral health initiatives. So we work with payers, states, counties, large providers on their substance use and mental health initiatives. And I'm here today to talk about the opioid settlement. That's one of the big things that we do is help counties and states put together their facilitation and settlement spending plans, which sounds pretty boring, but it's actually kind of exciting to work to improve the evidence-based spending. And so that's a lot of what we'll talk about today is how does this apply to OTPs? What are the trends in opioid settlement spending? What does it look like in your area? Some areas will give some sample areas so that you can put this in action and you make this work for your OTP or whatever program that you're working with. And I will just say, like, first time I heard Sonara, I wasn't sure what to think, but then the more I talked to them and realized that this is a way to get people back to work, more time with their families, not driving so far if they lack transportation. I really bought it a lot because I realized that this is going to keep more people in treatment. It's going to get people better recovery. And being a person in recovery myself, I understand how much time commitment goes into some of I was in a physician health program myself, and I spent many, many, many hours every week getting to and from testing and then the special hair test I had to come back from the mountains and going to the counseling that they made me go to and going to the next counselor that they wanted me to go to. And I know that many of your clients spend a lot more time than I did. And so any way that we can help people stay in recovery and have better quality of life, I'm totally on board with. So the settlement can help do this. Thanks, James. So we're going to talk, no preconceptions about what you know about the settlement. We're going to start from ground zero and get you to hopefully a place where you can go out and access some of the publicly available information about the opioid settlement in your state and your county, figure out where the money's going, and then if it works for you and for them, to make an application for that. So we'll spend a lot of time on that and give some concrete, here's the websites to go to, here's what to do next. By the end, we'll go through some examples of how settlement money and other money too, because there's still other money coming out, not just settlement money. Talk about how that's looking. Obviously, there's not enough time to do a comprehensive analysis of that. We'll talk about a few different examples that are really recent and really material to OTPs about how money's coming out, and then a preview of what's coming up soon. And then, like I said, we'll talk about how you can get involved, no matter whether you're for-profit, nonprofit, where you're located, and whether you want to use Sonara or not. This is the way anybody can help to expand their program. All right, next slide. So this is the big picture. The opioid settlement is massive and long-term. So that's something to keep in mind, that this isn't going away, but there is some time sensitivity to it. So you've got 50 billion. I think it's actually a little bit more than that now, 48 or something, but it's getting bigger all the time. Every time you hear about a new settlement with a drug company, a new settlement with a consultancy. I think the most recent one was actually a marketing company from France, and they helped some of the distributors and Purdue, I believe, some of the drug makers market their opioids. And it was even that one, a foreign marketing company. It was hundreds of millions, even billions. So these are 9 to 10 figure settlements, really, really, really big, some 11-figure settlements, I think. And they include all the big pharmacies, except Publix in Florida. I've heard that they have not settled yet, but CVS, Walmart, Walgreens, I think Rite Aid is on that. Drug makers, there are a few of those. Teva, which makes generic Oxy, Purdue, which made OxyContin, a consultancy, McKinsey, which helped with marketing plans for Purdue. And then the big ones have actually been organizations that you probably never heard of, like Cardinal and McKesson, which are drug distributors. And so those are the organizations that actually get prescription drugs into the hands of pharmacists. So lots of different organizations, and I think there are still some coming. So as long as there are more coming, this number 50 billion will increase over time, already a very, very large number. And that goes to participating states, regions, towns, Indian tribes. I think those are the 4 major subtypes. And some of those are participating through national litigation, and others have gone their own way. So there are, I think, 4 or 5 states that have actually had their own lawsuit and brought in money for their state. I think Oklahoma is one of those. But nonetheless, every state, county, town in America that I'm aware of is receiving some of this money. So that's an important takeaway, is that if there's an area that is not covered by this, I'm not aware of it. And so this is long-term, lots of money, and everywhere, which is a really, really, really good place to look for funding, especially if you're a national or statewide organization. And you see the bottom bullet point there. This does not displace any other funding. So nobody, no federal agency, no foundation has said opioid settlement will take care of it, so we're going to reduce our spending on behavioral health. You've got state opioid response there, and tribal opioid response, SOR and TOR, substance abuse block grant, and there's a prevention in there somewhere, and then ARPA. So a lot of states are still spending their COVID money, their ARPA money, and this is putting an unprecedented amount of money into behavioral health, and a lot of that's going directly into opioids. So keep that in mind. Focus on the settlement, but don't focus too much on it, because we'll go over some funding opportunities that are settlement and some are not. And honestly, the main reason the settlement is so good is that it's really, really, really broad. There's almost nothing, especially in an OTP setting, that would not be an allowable spend for opioid settlement funding. Smaller entities like states and counties can circumscribe what they want to spend on, but Exhibit E, which is part of the settlement, and you can find online, there are 105 or 108 different things you can spend money on. Anything in an OTP, naloxone, product, counseling, all those things are allowable spends. Now, that doesn't mean you can displace Medicaid funding or commercial payer funding, but it does mean that you can get pretty creative with what you do in an OTP. And we'll look in a couple slides at some of the priorities, and you'll see how crucial OTPs can be in those priorities because of what you do. Next slide. Okay, so first, some examples of what this looks like in different states and counties. Every state's different. That's the best way I can summarize this. There is a uniform, for the most part, uniform settlement MOU between the list of what items, Larry? Sorry, I can't, if I see a question, I can't help but take it right away. So Larry, if you go ahead and follow up there, I will try to address your question as soon as possible. Examples of state structures, really every state is different. As I said, there's a memorandum of understanding from the National Settlement Administrator to each state. That's pretty similar, but within the states, they do any number of different things. And I'll try to give you an idea of what is a range of normal things that they're doing. Basically, I would say some of the money goes to the state, some of the money goes to towns and counties, and the percent is very different in different states. And then in some states, they have set up nonprofit organizations or used existing nonprofits or like pass-through foundations to put that money out. So it's a little bit different than the state putting it out directly, but they are usually statewide. So I'll go through a list of items that you can use. Oh, yeah, absolutely. I think if you just type in Exhibit E opioid settlement, you will find that online pretty easily. It's very well publicized. All right, so some of the average, I guess, ways of putting out money. And this is important because this will help you decide whether to look to the state or to look to your county or some other type of entity when you're seeking funding. So this actually is important. And I know we don't have all the states on here, but I'll tell you a place where you can go and figure this out very easily for your state. So an example, Colorado, we know this one well. We actually run 9 of the 19 regions for facilitation here. So we are the most experienced firm in the country at facilitating opioid settlements in Colorado and outside. We've done some in Oregon, Kansas, and hopefully Florida next. We have 19 regions, and these are either big counties on their own. So Denver County has its own money, or in smaller areas, they will put together, I think, as many as 7 counties so that there's a significant amount of money. And the money still differs. I think the smallest region got about $500,000 in the first year, and the largest region got about 7.5. So very, very large differences between the rural and the urban areas. And those are probably larger amounts than you'll see in most states. Our state did really well for the counties and cities. So 80% of the money in Colorado goes to counties and cities. And a lot of the money from the cities actually goes back to the counties. So if they're medium-sized or smaller city, a lot of them are just giving their money back to the counties, knowing that they will spend money on things that benefit their city. So 80% to localities, 10% to the Attorney General, which they have put out through some innovative grants, one of which is currently out, and then 10% to our Opioid Abatement Council, which is a state committee run by volunteers, providers, people in recovery from throughout the state. And they have put out about 8 million, I think, in infrastructure grants. So they, each of these entities got to decide how they put their percent out. And so we help the counties put that out. Often we look for specific priorities that are aligned with those counties' community health improvement plans. So we look at their prior community health improvement plan. All of them have prioritized behavioral health, and a lot of them prioritize substance use specifically. So a lot of times they have done some work that says, we want better care coordination. We want more counselors in our area. We want more medication for opioid use disorder. And then we get it put out in an RFP specifically for that purpose. All right, other places, like I said, doing it very differently. Florida is divided by county and city, and they have a negotiating committee, which I don't completely understand, that has a representative from the state and 2 from the local government. And I guess they just hash out how they're going to spend their money. And Mississippi, totally different. Most of their money actually goes through their University Center for Addiction Medicine. And I read as much as I could about this. I think that the center is going to spend some of it. I assume that they will put some of this out through grants, but I could be wrong. And as you see there, just a minority of their money is actually going out to counties and cities, 15% compared to 80 in Colorado. So very, very different. And like I said, I am sure there's a rhyme or reason to that. In Colorado, we've got urban areas, we've got very rural areas. So I really like the fact that localities get to decide how they spend their money. But there's still some at the state level to do things that are good for the state as a whole, or say to put together a larger treatment facility that's going to benefit the whole state, but no region would want to fund on their own. So I'm obviously biased. I think Colorado did a great job. We won an award actually for transparency in spending. And there are a lot of other states that are doing great work, transparent spending. There are some that are much less transparent. And so Like I said, these are the main structures, putting it out through the state or the city and county. And then also that Center for Addiction Medicine. There are other places where, like Kansas, they have chosen the Sunflower Foundation, which is a big philanthropic foundation in Kansas, to actually put their money through. And so their money goes through a philanthropic foundation, gets prioritized just like it would at the state level, and then put out through RFPs. So some of these differences will matter. Mostly the big thing that you want to know is it here at the local level? Is this something I need to look to my city, talk to a city councilor, or do I need to go to the county level, talk to a county commissioner, maybe our county manager? Or is this something I should be looking for a statewide committee or talking to our attorney general about? And I'll talk more again about how to find those sources as we get a little bit closer. Next slide. Okay, so here's some examples. I've just got time for about 3 examples, 2 of which are opioid settlement, 1 is not. So there are a range of different opportunities, and they're all really important. This one from Macomb County, this is suburban Detroit, and they did a procurement. It's really more like getting in a network. So a lot of places, and this is true for state Medicaid, it could be true for your county human services, could be true for your parole and probation. It's really common that they have selected providers they work with. And actually, this doesn't come with funding, but in order to treat people in, Macomb County community mental health system, or say the probation system in X County and Denver County, you have to get credentialed. And this helps you to expand your client base and offer additional services, because sometimes they'll let you offer services beyond your normal fee-for-service rate within some of these. And so it's a good opportunity to expand your client base, but not a grant per se. So that's one recent procurement that came out. And it's important to be in those networks, because if you're not, it's not going to look good on your grant application. So if you're not accepting all the public players that you can, Medicaid, parole, probation, things like that, you're not going to have as great a case when it comes to opioid settlements. So let's look at one of those in the next slide. All right, so this was a pretty big one recently. I think this was due in January, and it's a city. So they put this out. It's a really typical settlement grant. So this is probably the most, I would say, normal, if there is such a thing, settlement grant I've seen recently. And it has a lot of different uses. They name them here, but it's a lot. It's treatment, it's recovery, it's prevention. And that's the key for you to look for as an OTP. Obviously, look for treatment, especially medication-based treatment. A lot of people still use MAT, M-A-T, as the acronym. Some use MOUD, but they have these telltale signs of medications approved by the FDA, and then also ASAM criteria too. So usually they're looking at not just medications, but also counseling, also works for OTPs. And here, the nice thing here was the amount. So Louisville, obviously big city, and they must have done very, very well in their negotiations. What I think I found was 57 million. That sounds like an awful lot. One thing to know about this, as you look at spending, so you think 18 years, a lot of these dollars are coming in at the beginning. It's extremely front loaded. And so that's why you want to be ready today, yesterday, hopefully, for some of these grants, because the money, the way the settlements worked is a lot of the organizations paid up front. And so they paid their whole 600 million in year 1. And that gets put out as soon as it's processed. So it goes from National Opioid Settlement Administrator to the states. And then from the states, often there is some little pause where you submit a report or something like that. And then it goes out to the counties and cities. So there's not, the state does not hold on to it and parse it out over 18 years. They put it out as soon as they get it. So good example, I think our biggest county, which was El Paso County and Teller County, had I think it was 6 or 7 million in year 1. That's going to go up in year 2, probably into the $10 million range. And then it's going to drop really, really, really rapidly. So probably into the $2 million range for year 3. So it goes from X amount to almost 50% more to 80% less. And That's going to differ state by state. It's going to differ county by county, but the general trend will hold that this money is going to come out this year, next year, maybe one more year, and then it's going to become a small trickle. And so if you have capital improvement projects, if you have projects that are one-time expenses, this is a really good time to get on board because there's a lot of money. And in some places, it's more than they're getting applications for. Not everywhere, but some places. So like I said, this was a great example. It is very open. And so the next one we'll see actually is a more circumscribed group of services, but one that also works well for OTPs. And this one was in El Paso County, Colorado, recently closed, so they're not accepting applications anymore. But this is also a very typical settlement grant, different in that it's specific to a certain scope of work. And this is how we've facilitated, I think, really all of our communities so far is we want to get beyond that. Everybody send us applications for everything to some things that are specific priorities for the county or for the group of counties. So taking their community health improvement plan, taking their overdose data, their ED admissions, their naloxone data, any data we can get our hands on, and trying to tell a story with that about what's there, what's going well, what's missing. And so obviously we look at OTP locator from SAMHSA, we look at OTP licensure, we look at OBOT, we look at Suboxone prescribing. It's a little more difficult to figure that out, but we do look at how does the prescribing or the methadone administration rate compare in this county to neighboring counties? How does the overdose rate compare? And is this a place where there's a relative dearth of opioid treatment programs? So in El Paso County, and especially the county next to it, Teller, we determined that there's definitely not as much prescribing as you would expect for a big city with a pretty high overdose rate. Their overdose rate's pretty on par with the state average, and their Suboxone rate is like a fraction of some of the other counties, and they only have I think they have 3 OTPs for a city of about 700,000. And so just based on that, we're able to say, look, you have less than average MOUD, and so accepted applications for MOUD expansion. And you can see that it's a little bit small, but we set specific goals around number of providers, number of individuals accessing MOUD, and then supportive services like counseling, case management for people in MOUD treatment. So I would say that the 2 big ones that you're looking at, are 2 big kind of like broad categories are really broad grants where they just ask for applications for anything that's allowable spend. And like I said, OTP is definitely an allowable spend. Others where they have maybe a specific treatment RFP, request for proposals, where they're looking for either counseling or medications or both. And so those are 2 things to keep your eyes open for. And often these will say opioid settlement, opioid abatement grants are often what they're titled. So make sure that you are signed up for listservs in your state around substance use. If you're engaged with your opioid treatment dependence organization, COTAD, ATOD, hopefully they're putting some of these out too. But make sure that you are, if you're not sure where they're going to come out, talk to somebody. And like I said, city councilors, county commissioners, attorneys general are probably the most in the know types of folks where these are coming out. All right, next slide. Okay, so now we're going into that of how you can get involved. So there is best practice guidance, and Phil is going to go through a different one on one of his slides, that we don't have to reinvent the wheel to know what to spend on. So there were some very lots of letters after their name that got together a few years ago. These are now about 3 to 4 years old, where they got together and went through what is the evidence for prevention, what's the evidence for DARE, what's the evidence for OTPs, what's the evidence for case management, and put together a list of ways that almost every region could best spend their money. And I find these really helpful because, again, we don't have to start from ground zero. We've got ideas about what works. We know what's cost beneficial. We know, and that's where our approach, I think, is really good. We try to address local issues, but we also recognize that a lot of issues aren't just local, right? There's probably not enough medication-based treatment in almost any community. And when I say there's not enough, I mean, not enough people are getting it. It may be available, but there's a mismatch of people who could benefit from it and who are getting it. There's probably not enough naloxone in a lot of states. I think there's some states where they've got a big fund, Medicaid benefit, and maybe we're reaching peak naloxone. But I think in most states, you can confidently say that naloxone, higher naloxone distribution amongst people who use drugs would really benefit overdose outcomes. And so they put together all these ideas and voted on, I think it's 10 of them here or 11 of them, and categorized them into what goes where. Actually, I think we categorize them into things to help folks. And I'm actually going to start on the right because I think most of the money that you as an OTP or really anybody local is going to look for is going to come through your city and county, and then also your state. So I'm starting from the right here and moving to the left. Actually, no, let's start from the left and we'll build up to the big one. So national, expand Medicaid funding for drug user services. So these are more like federal level, and you see the Stronger Act in Congress right now. Great example of the way that they are actually actionalizing some of these recommendations. More Medicaid funding for drug use services, right? More Medicaid funding, less stringent rules around medication distribution for effective treatment. National Anti-Stigma Campaign, great. We fund these in almost every region. I find them very, very helpful so that people start to think of people who use drugs as neighbors, humans, and also start to think about treatment as normal. And those two, to me, go hand in hand, the anti-stigma and the treatment availability. And then the last one, they want a National Nonprofit Watchdog Coordinator for Settlement. And I would say right now, Kaiser Family Foundation, they have a great reporter named Aneri who is doing a lot of this watchdogging, not coordination, but talking about who's spending the money well, who is maybe not spending the money as well, to shine a light on areas where a lot of the money is going to not evidence-based treatment, so that hopefully those areas feel a little bit more beholden to their taxpayer base to spend it on better things. All right, so moving to the right, getting more close to the actual money, those are more policy issues. Cheaper naloxone and MOED. And so I think what you're going to see in the middle and the right columns, how many of these relate to OTPs? How many of them? 2 or 3 in the middle and all of them on the right. So this is why this should really be a good source of funding for you, because so many of these evidence-based practices that are underfunded are services offered by OTPs. So you see cheaper naloxone and MOED, absolutely. Naloxone especially is pretty expensive. MOED is, most of the oral versions are actually pretty cheap. So pharmaceutical opioid supply, this is really getting to kind of prescription drug monitoring programs, making sure that opioids don't get overprescribed, but that people who can benefit from them, people with chronic pain, are able to access them. So I guess that's really the last one that's really not OTP relevant. And punitive approaches to drug use and reform the criminal legal system. And then community development, so schools, housing, things like that, I also think are fantastic uses of funding. And you see some states that are investing federal funds and opioid settlement funds into things like housing, which are not nominally opioid related, but are clearly part of the solution. And here, remove absence-only conditions. So a lot of OTPs, not absence-based. So I think this plays right into your priorities as well. Moving on to the local aspect. Again, all 4 of these are things many OTPs do. Naloxone distribution, I know a lot of you put out naloxone directly to your clients, which is saving their lives. Second one, safer use supplies and low threshold SUD treatment. Again, I'm sure you know this, OTPs are usually one of the lower threshold options in the area. And evidence-based treatment, they're getting at things like medications, contingency management, where you give people small incentives for abstinent urine drug screens. And I know that some of you do that in OTP settings. And then the last one, MOED for justice involved people. I know also a lot of OTPs bring methadone and buprenorphine into their jails, into their prisons, so that their clients can continue to receive that while they're incarcerated. So I hope this really gives you an idea of settlement money I shouldn't say should. Settlement money is right for OTPs, that you provide a lot of these services that are evidence-based and in line with best practice guidance. So as you're writing your applications, I hope you use this. This is one of the national settlement guidelines. I think it's the one from Harvard FXB, but I could be wrong. There's also a big one that Phil's going to go over from Johns Hopkins, and talking about how your services align with best practices is a really good way to justify your grant application. Okay, so I don't have time to go over all the things that you should do or not do in a grant. I know some of you might have not have written grants before, and you might say, "Hey, we're a for-profit, we can't get grants." First thing I would say, not true. Most, not all, but most of that, the RFPs in Colorado have been open to all types of applicants. So C3s as well as LLCs or other for-profit structures. I would just check that when you see a grant come out. First thing I would do, I mean, I do this for us, we're a for-profit agency, is look and see if for-profits can apply. And they usually should state that pretty clearly in the eligibility criteria. And in most places, I think they recognize that a lot of the organizations innovating, and especially in the medication-based arena, are not nonprofits. And so I'm really hopeful that when these come out in your county and your state, that you're eligible, whatever your tax status is. But I would say, even if that's a no, don't totally count yourself out, because we do this a lot. If it's just for a nonprofit, we'll partner with a nonprofit as a subrecipient. And so if there's something that we can contribute to that, the nonprofit will be the applicant, and then a for-profit can be a sub-applicant or a partner in it, subcontractor. So if you've got some really close nonprofit partner, say a county jail or something like that, talk to them about what they want to do and see if they would put you on as a subcontractor. So don't rule it out totally, but I would have separate ideas for, are we eligible as an applicant? Are we eligible as a sub-applicant? And that goes into the second one. Make sure you built these partnerships before the grant comes out. I just saw one in Norman, Oklahoma, and it is due March 5th, and it came out today. So that's 1 week. Which tells me that they have some ideas about who's going to apply already. Also tells me that they want people who can move rapidly. If you need to make a lot of calls, if you need to sign MOUs with people, you're not going to get this done. And so have your plans and your partnerships built well in advance of grants coming out, because for most people, they'll be eligible for more than one grant. You'll be eligible for some type of statewide grant coming out from your state or your attorney general, sometimes multiple of those, maybe something from your county and maybe something from your city, because this one is actually City of Norman. So there's probably a City of Norman grant. There's probably is it Cheyenne County or something like that? Probably a county grant, and then probably one or more of their state grants. So there's 3 grants they could be eligible for that all might look exactly the same. And so we're seeing this too. Denver's grant applications look just like Colorado's. And so you could apply for almost the same thing in Denver and Colorado at large. So keep that in mind. You're not just making this for a one-time deal. You're making it for this, as well as non-opioid settlement related projects. Okay, so what not to do? I get to see a good amount of grant applications and like what not to do. So one thing I wouldn't generally do is apply for really distant grants if you're a out of town, out of state organization. We got one from an OTP in another state. It was really clear they'd never set foot in the county. It was really clear that this was very opportunistic, but also not, frankly, that welcome. There was no reason to think they would come in and succeed any more than the, I don't know, 38 OTPs we already have in Colorado. Like, if we wanted somebody to do OTP services in this county, we just asked somebody who was nearby. So I would be very selective about that, how you're applying for things out of state if you are providing local services. Obviously, there's organizations that do things on a national, statewide level, and can do things very quickly in disparate locations. OTP is not really one of those things. You got to be there. And also, you've got to spend some time individualizing these. This particular one, I remember it was clearly written by AI. It was, you know, oh, so-and-so county has 6 cities and 5 census designated places with a total population of 300,000 people. And we didn't read very much of it. It was really bad. Second one, make sure you look at the services. This is one we see pretty consistently, and make sure it matches really well. So again, if it's a more broad grant, like you can apply for anything that's an allowable spend, absolutely apply for it. If it's something that says they want treatment, before you apply, look at it and make sure they want medication-based treatment. You know, if they want just counseling, you know, OTP might not be the ideal applicant. So just take a second and look through the scope of services and make sure that you match really closely. I was on a call a couple weeks ago where they got very detailed about, does this organization exactly do the thing that we want, and actually eliminated some folks that, you know, had pretty decent applications, but were a little bit outside. You know, they want to do, they mentioned mental health a lot. Well, this is an opioid grant, so mental health's not going to go over well. And for this line, treatment, for some reason, a lot of people conflate recovery and treatment. So this is the one exception to rule number 4 here. If you see something that says substance use recovery grants or opioid abatement recovery grants, do look through it and see what they mean by recovery. A lot of places call those two the same thing, and they don't have the same, I guess, division that I kind of have in my head around treatment being billable and recovery not being billable. So sometimes recovery will include formal treatment, clinical treatment, medication-based treatment. All right, next slide. Oh, perfect timing. This is my last slide. I'll hand it back to Phil. So things you can do to get involved. Biggest thing that you can do, go to the opioid settlement tracker. I think it's literally opioidsettlementtracker.com. There's a lot of information on there. Find the page that shows the statewide breakdowns. It's got like color-coded columns, and it says 50-50, like 50 county, 50 state, or for Colorado, 60 county, 20 city, 10 state, 10 other. And that will tell you where is the bulk of your money in your region. Are we 90% of the state? So I really need to look at the state website. I think most of them have that by now, and figure out, when is this coming out? Start to look at meeting minutes. I know that's kind of painful, but see where they are in the process and try to get an idea for when things are going to come out and where they're going to be. Get on their mailing list. Opioid Settlement Tracker really is the best way to find your way to that in every state. I use it all the time. They even have a site that keeps up with some of the grant opportunities. They don't get all of them, but often they'll have opportunities like getting on your state council. So actually speaking up about what should we be spending our state's money on around opioid settlement, and that's something you can do too. You probably want to think about, are you going to be an applicant? And if you're going to apply, it might not be great to be on the state council that decides how it spends the money for conflict of interest. But it also is really important to make sure you've got people who will speak up for OTPs and similar services on those statewide and on those community boards. So your state advocacy organization, make sure that you've got somebody who's at least familiar with that, if not directly involved. A lot of the local groups, you can get involved. So in all ours, I think every region we've worked in, these are open meetings. Anybody can show up, anybody can comment. Sometimes they restrict like open comment to 5 minutes, right? You can't show up and like be part of the work group, but sometimes you can. And so being there and helping them, talking about, here's the cost benefit of OTP services. Here's what OTPs do that other places don't do is really important, because sometimes, when we facilitate, we have a physician, we have a clinician on staff. A lot of counties are doing this with a county manager, some city councils, and people who know a lot about a lot of things, but not necessarily about behavioral health. And so having someone who's an expert in treatment is really, really important. And for us, it's really welcome. So try to get involved in those governance committees and don't try to influence the outcomes, but just talk about, pipe up when they ask about ideas. And if you're not sure after reading Opioid Settlement Tracker, talk to somebody, like I said, attorney general to state level, county manager, or a city councilor or a county commissioner or city councilor at the local level are probably the most likely people to know at least what's going on, if there are meetings happening, where you can get plugged in. And as I said on the other slide, make sure you've got appropriately sized projects for funding. This is where it gets a little difficult. What is appropriately sized? It's different in in El Paso County, where they have 7.5 million. I would say appropriately sized is anywhere from 100 to a million. If you're in a really rural area, appropriately sized might be 10,000 to 30,000. So this is where knowing the breakdown of your state's dollars will really help. If you're a state where not much money is going to the city, and you go to the city with a $200,000 ask, they may not like that. And unfortunately, not all the RFPs actually specify how much money they have to spend. So you have to start to ballpark this. But nonetheless, disregarding appropriate size, think about what you want to do, what you do with $50,000, $100,000, and why you would do it. How has the community informed this? How has your data informed your project so that you're ready to put that down on paper? And who are you going to work with when it happens, so that you make the best use of collaboration? So those are my top ways to get involved. And I'm going to look through chat, but first I'm going to hand this back off to Phil to talk about partnerships and OTPs.
Yeah, thanks, JK. Yeah, Sonara Health has applied for a number of state opioid settlement opportunities, as well as SOAR grants, as a sub-applicant or a subcontractor for opioid treatment programs around the country. We've been successful in a number of situations where the funding is able to be awarded to the opioid treatment program, and that opioid treatment program can supplement their services and really support increasing access through technology to medication-assisted treatment. Johns Hopkins was heavily involved in this and really published their 5 guiding principles when looking at how are these settlement dollars weighed and appropriately selected participants to receive these dollars. And we've used this as part of our support to the grant writing process. So we have grant writing experts on our team that work with the opioid treatment program and really help formulate the grant application or the opioid settlement application to increase the likelihood of award. And these 5 guiding principles are critical for this. So when you look at spending money to save lives, the dollars that the opioid settlement funding is representing should supplement rather than supplant. And you heard JK say that earlier. The idea is, how do these localities increase the spend in access to treatment and options that will immediately save lives? And we look at that congruently with the treatment program supplementing and augmenting their treatment program. So if you're requesting money and not adding a way to increase access or to increase your portfolio or your partnership, it becomes difficult to surmise why you're asking for the increased funding. The second principle was use evidence to guide spending. So they want to direct funds for programs that are supported by evidence. Obviously, that's important in medication-assisted treatment. There's a principle of investing in youth prevention. That one, it has been critical in the selection and award across the various principalities. Focused on racial equity, and not just racial equity, but equity in general. But this is really critical when it comes to applying for these grants. You want to link to community-based services and harm reduction programs, but increasing equitable access to opioid treatment to really diversify the communities that are able to receive access to this treatment and ultimately save lives on that first principle. And then the last one that Johns Hopkins said is really making sure that these opioid settlement dollars are transparent. You heard JK touting how the award was received in their county about transparency of the process and the fair and transparent process that opioid settlement dollars are able to be observed and identified who's receiving that funding and how that funding goes immediately to saving lives and impacting the epidemic. So the applications that we focused on with these 5 principles in line really focus on these criteria, and it doesn't need to be something where Sonara increases access to medication-assisted treatment through technology. This virtual dosing window and our platform of remote engagement is just one way to innovate an opioid treatment program, but there's a lot of partnerships, and we encourage partnerships as the avenue to augment or supplement your current practices and the way you provide treatment to your patients, as a way to really reach more patients and bring access to that medication. Use evidence-based when possible. By all means, if there's an innovative partner or a potential community member that you could partner with as form to change the way that practice has been done, supporting that with any evidence, research studies, or data that comes from them would be critical in the application to reduce barriers in treatment. Focused on improved patient outcomes and retention is critical for the success, which really links back to that first point that you saw in Johns Hopkins of saving lives. And then the last one, and JK touched on this a bit, there's a great amount of funding immediately. And the goal is this funding can really bring these innovations to the opioid treatment programs, but then linking a sustainable way, a go forward way that this program becomes part of the opioid treatment program long term, and how the program intends to have this program go ongoing after the funding ends in 1 to 3 years, depending on that particular grant opportunity. And with these areas of interest labeled with the 5 principles of how these grants are selected, Sonara has been quite successful at supporting opioid treatment programs, innovating their partnership with us, and innovating the way they provide treatment and access to medication-assisted treatment, and expanding their scope of region that they can reach through technology. So we encourage you to ask questions immediately. We'll ask questions here in a minute, but right before, you'll also see a little poll pop up with a questionnaire. Feel free to respond to those questionnaires or to that poll, and then we'll hop right into your questions. JK, have you been able to review the chat, and do we have any current questions? Others, if you have questions, now would be a great time to put in the chat.
Nothing currently, but we're waiting for them.
Hey, we have a good 10, 12 minutes for you, so feel free to ask away.
Here's somebody asked for a link to the allowed strategies. So this is Exhibit E. This is, I believe, true for every state, or pretty much every state. And you will grow tired of reading them pretty quickly. There's a lot of them, and I have not found anything that is reasonable in my mind that it doesn't fit somewhere into here. It's everything from data to medications to interventions for pregnant and postpartum women to case management, all those things. Anything that goes on in an OTP falls somewhere into these allowable spends. All right, while we're waiting for questions, one thing I want to reemphasize. Can you go back to the last slide, Phil? One thing I would say for OTPs specifically is a smart reviewer has an understanding of what's going on already and what's new. And they want new stuff here, right? Next one.
Yeah. This one?
Yeah. And so the augment or supplement current practice is really important, because we've gotten applications from OTPs that were like, fund a counselor, which is great. You know, I realize in a lot of places there's a lack of counselors. It's not new. And it's also something that you get reimbursed for. And you might not get fully reimbursed for it, but at least some percent of that counselor's salary is getting reimbursed through Medicaid, private pay, commercial. And so things that change your delivery model, that add to it, especially things that you can pay upfront for, are really, really, I think, what a lot of places are looking for, where they can make an investment and it's going to pay off for years. You know, you hire a counselor for a year and say that they're doing something really novel that they don't get reimbursed for, but you still just have a counselor for a year. And if you don't have some sustainability to that, then it's not going to work out well. So think about things that go above and beyond. That might be a building for some places if capital, especially if you're a nonprofit, if capital is a barrier to expanding your services, that may be a good use of services, or good use of funds. And they'll often give you an indication of CapEx if that's an allowable expense. A lot of places it's not, but sometimes it is. All right. Abe asks, have you seen dollars being earmarked for tech, patient-centered case management? There's several questions in here. I'm going to answer those first two. Great question. So I believe there is an open or recently closed Massachusetts tech. There's a grant, and I don't think it's even settlement related. It is specific to tech around behavioral health. So that is actually the first one that I've seen that is specific. We are just funding platforms, like not necessarily startups, but tech. Others I have not. I've seen applications from tech companies, usually in concert with a local provider. Trying to think of examples. I've generally seen like tech platforms as subsidiary grantees. I think I guess I've seen, this isn't really tech. I've seen analytics firms apply for to process data, to make a dashboard. So if that's the kind of tech you're talking about, yes, I've seen that. No, I haven't generally seen dollars earmarked for it necessarily. It's kind of part of a broader group of applications. Next one, patient-centered case management. I haven't seen that as like the priority or like, dollars specific for that. But again, that falls into all these allowable uses. We've definitely seen case managers show up on applications as funded positions. My big question is, what do you do the next year? How's this case management going to level you up so that it's better in 2026? I guess putting those two together, like tech and case management, if you could make an investment into a platform that were to, improve your care coordination, standardize your referral process, keep metrics on that, you could make a good argument for that. Okay, and then the third question is, any good ways to get an MOU with state organizations that control the data? That's a whole other question. No, is the big answer. We get data from state agencies through like relationships because we know them and they know us and we live in their state. And I have not found, you can make we call them core request, call it an open records request. That's usually pretty slow and doesn't make you a lot of friends. And so, no, sadly, I've just found it like, you've got to know the person, call them up and say, this is why I want the data. And if you just fill out the form on the website, you might get it, but it's probably not going to be time sensitive. That's just been my experience here in Colorado.
That's our experience, exactly the same across the country. It's relationship building those partnerships ahead, which really goes to that one of those first talking points you had, JK. Having these conversations up front, building those strong relationships and partnerships is key prior to the grants being submitted.
And then I guess the one place I'd say we've had some success is with private organizations. So like plans is really who I'm thinking of. Plans seem to be infinitely more willing to share data with us than the state itself. Partly because we're usually offering them something, hopefully of value to them. Hey, we want to analyze your data, to help understand the treatment landscape. And they also the plans need good PR. The state doesn't. So plans have been surprisingly willing to share data with us. So that's where I'd go, assuming that you have managed care. I think I know New Mexico. I'm sure you have some managed care entities. That's who I'd go to for data, especially if you're talking about claims data. That's where I'd go. Julia has a question. We are a harm reduction supplier and education-based nonprofit. Do you provide letters of endorsement or grant proposal reviews, or are you primarily focused specifically on OTPs? I assume you're talking to me. We do grant writing, review, things like that. Yes, and I'll put my name in the chat if anybody wants to contact me. You got time for about 2 more questions. You want to put them in the chat.
I think we're questioned out.
Cool.
Excellent. Everybody, thank you so much for joining. Please feel free. JK has his contact info in the chat. We will send out a link with a recording to this afterwards. If there's ever anything either of us can do, please feel free to reach out. The reality is there's a great amount of opportunities out there. The goal to this entirety is how do we impact the most amount of people as fast as we can and make a difference and ultimately save a ton of lives through this program. We think it will. We expect that we'll continue to work together and develop these partnerships and develop this way where we can all leverage this funding to ultimately make a difference in our communities. So JK, any final thoughts before we end the call?
Done for me. I thought that was a great way to end the call. Thanks for coming, everyone.
Excellent. Thank you, everybody.